Good afternoon, everybody. We're going to get started. Again, this is Joe Vijay, Health Information Technology Integration Coach here with the Integrated Delivery Network and the North Country Health Consortium. This is the second series in newly developed webinar series the IDN is offering, and today we're going to speak to risk stratification for enhanced care coordination. More on that in a moment. The session today does offer continuing education for our IDN 7 partners, and we're excited to offer that for folks. We'll give you some more information on that later on. These are the required disclosures for the continuing education process, so we just want to put those up for a moment. And I'm going too far ahead, I apologize. Let me fix that. There we go. Today's learning objectives for our webinar, again, a requirement of the continuing education process is that we will identify 3 components of a coordinated care practice as defined for the integrated delivery network. We'll speak to components of a core comprehensive standardized assessment and demonstrate the importance of and describe the types of risk stratification models for care coordination. So let me introduce our presenters today. Today, we're really excited to have Jill Gregoire with us. She is a member of the team here. She works as a quality improvement coach at the North Country Health Consortium. She's part of the Practice Transformation Network team here and does a lot of work with practices around quality improvement processes and various programs. She does a lot of policy development, workflow analysis, and has used this model with a couple of IDN partner practices to look at risk stratification and how that can help identify the patients who really should be at the top of the list for enhanced care coordination to try to improve outcomes with those folks and use resources better. So we're excited to get into this topic today. If you have questions, we're going to ask you to kind of hold on to those till the end if you can, or type them into the chat window, and we'll get to them at the end of the session in the Q&A portion, just so Jill can move through her presentation. So with that said, I'm going to turn it over to Jill, and we'll begin our presentation.
Hi everyone. If you can't hear me or have any issues, just type into the chat box, and Kayleen is monitoring that so that she can help me out helping run this. When I put this presentation together, I really wanted to focus on the IDN project core components so that our partners really understood the rationale behind care coordination, which requires risk stratification. So risk stratification is a component of care coordination, but the real bigger picture is becoming the coordinated care practice or an integrated care practice, which is what the IDN project core components are. So they want to provide training and support to primary care, community mental health centers, other network medical and behavioral health providers for becoming a coordinated care practice or an integrated care practice. I'm going to focus mostly on coordinated care practice because that's really where the risk stratification pulls in to the components. What the IDN or the DHHS has stated to become a coordinated care practice, that practices must use a comprehensive core standardized assessment process annually and a shared care plan that's individualized. This CCSA, which I'm going to just so you know, that's the Comprehensive Core Standardized Assessment. I'm going to abbreviate it CCSA, is done over a 30-day period. You can do it in 1 day, or you can take 30 days to do it, depending on the type of practice that you have and the type of care coordination and resources that you have to get this done. The assessment process, and I don't know if you noticed or not, but process is all capitalized, and it's specifically capitalized because it is more than one thing that needs to be done. So it's not just an assessment that needs to be done. There's multiple domains that are required for the CCSA process. And that is collection of demographic information, medical information, substance use screening and information, housing, family and support services, education, employment, entitlement, and legal, and risk assessments, which includes depression screening and suicide risk, and then functional status, ADL's cognitive function. A lot of these domains we are already assessing. It is a standard to assess most of these in a primary care practice and specialty care practice and behavioral health practices. There are pieces of this that each of those organizations already assess. There are pieces that need to be implemented to gain all 12 domains. If you have a pediatric population that you are treating, they're also requiring a developmental screening process to be in place as part of the assessment. And that's an ASQ3, which is an ages and stages questionnaire, or ASQ-SE, and I can't remember what that stands for. Those are done at 9, 18, and 24 or 30 months, plus using Bright Futures or other, the American Academy of Pediatrics developmental and behavioral health screening systems. So they just really want you to use evidence-based practices to do your screenings and assessments on your population, and then use that information to create the individualized care plan that you actually share. So the integration part of behavioral health integration is integrating with primary care, behavioral health services, and also any social services that are happening and going on, in the social determinants of health assessments that have recently become vogue for implementation in primary care. Mostly, I think FQHCs have really standardized that assessment process. The other primary care private practices and community practices are getting on the wagon now in doing the social determinants of health assessments. But this is one thing that is required by the Department of Health and Human Services for the IDN, of all of our partners in the IDN, and the actual deadline for implementation of this is December 31st, 2018, in case you didn't know that. So why do we need to risk stratify to get this process going? Because to do care coordination, it needs to be focused on patients who are going to benefit the most, maximizing the impact on both quality and cost. There are multiple risk stratification models that are efficient tools for both providers and healthcare plans to screen populations and select individuals for care management programs who are at risk of future hospitalization and or functional decline. It's considered cost effective to actually look at your whole population and pick out the patients that need the extra attention for education, self-management programs, need linkages to different resources, care coordination. And the Department of Health and Human Services have provided some more guidance in regards to that they want the CCSA assessment tool to be a process, but using a tool that's standardized. It's a screening process that integrates the medical, behavioral, and social needs, results in identification of needs with appropriate referrals and linkages. The standardization part results from the screening of the core set of domain areas. The process is the basis for the individualized care plan that's used by the care team to guide the treatment and management of the target subpopulation. So for the IDN, the target subpopulation is the Medicaid population. IDNs must develop and implement comprehensive core standardized assessment protocols that detail the requirements for the assessment process, documentation, expectations of providers and training plan, tools used, referral process for assessment findings, and individual needs. So we do have some sample protocols that are actually, that we have done up and posted on Basecamp. that Joe can talk about at the end of some documents that are available for those organizations that are looking for some tools to help pull together their multiple assessment processes and put them into one protocol. And basically, they just really want to know what tools are you using to assess each of the domains, and then how often are you requiring that to be done. This is it's hard to see. I just cut and pasted a portion of that protocol. So this is the sample protocol and questions for the comprehensive core standardized assessment for the Medicaid population. And it just goes through each of the domains, what's required, what is a demographic, what's required for demographic information, what's required for medical information, some samples. It's in a Word document, so you can put in your organizational requirements that you have that are individualized. This is a tool that actually is the questionnaire or the survey that is given to the patient. It can be given either, I've got two organizations that are using this. One uses it as paper. It's given out at registration to Medicaid patients. Some of the scripting that they use when they're handing out the survey, because of course there's a challenge with getting patients to complete surveys, or all the paperwork. Just there's a ton of paperwork usually during registration. But some of the scripting that we've recommended is that your insurance company. So the state of New Hampshire is actually requiring this be done, that we do this with Medicaid patients at least once a year to do this assessment so that we can make sure that your needs are being met. So that's kind of the language that we're recommending to be used at registration. So I have one practice that uses it on paper, hands it out, and another practice actually has it electronically. It's on a little iPad that is used to collect information, the demographic information, and these questions have been added in there as well. So those are just some examples of how we can implement the CCSA process. And once the CCSA is done, it includes depression screening, it includes the SBIRT screening, and all of that information, all of that assessment is pulled together and given to the provider for the visit. And I'll show, I think I've got a workflow in here on how the provider then makes the determination. It can be the provider or the care coordinator that makes the determination of that patient's risk level based on the model of risk stratification that you have selected as an organization. So there's a couple that I have in here, and we'll talk a little bit more about that coming up. But so once you get into this, you've identified what level of higher risk or highly complex patients or patients that have complex needs that require care coordination. That's where the referral to the care coordinator happens, and the practice or organization determines what level patients care coordinators are actually seeing and creating the care plan, comprehensive care plans. And then they make a determination out of that subpopulation of patients who needs to be in this multidisciplinary core team model, which is available that support individuals that are at risk for or diagnosed with behavioral health conditions or chronic conditions that includes PCPs, behavioral health personnel, a psychiatrist, any assigned care managers or community health workers, and may also include peer specialists, pharmacists, social support providers, and pediatric providers as appropriate for the patient. And then as another part of the IDN focus is providing basic educational programs for the core team on how to work together as a team, but for behavioral health, what are the standards of care or training and management of chronic disease, such as diabetes and hypertension, dyslipidemia, And then for primary care, the nature of mental health disorders and substance use disorders, as well as training in how to work together in a care team. What is risk stratification? It's a systematic process for identifying, predicting patient risk levels related to healthcare needs, services, and coordination. The goal is to identify those that are at highest risk or are likely to be at high risk and focus interventions on these patients to prevent poor outcomes. Often, risk stratification involves the use of algorithms, registries, payer data, et cetera. Why risk stratify? We want to be able to predict potential patient health risks, prioritize resources, focus interventions, and minimize negative outcomes. How can we stratify risk? There are several different ways, and I've put the actual most common ways at the end because they are the easiest in a primary care practice for doing risk stratification. This is the most comprehensive way model that I have found is the American Academy of Family Physicians risk stratification for care coordination, basically for care management on how to do that. I'm just going to show you their tool that they use, and this is the one that most primary care organizations that I've worked with have chosen to implement. However, some primary care organizations have felt that it is too complex. And when you look at it, you can see complexity in how it looks because it's so comprehensive. However, the actual implementation of this tool is quite easy and quick. So I'm just going to go through and show you this. So this is risk stratified care management and coordination. It's pretty small print. You can get this on the website, the American Academy of Family Physicians website. If you put in risk stratified care management and coordination, you should be able to pull this tool up. And if you look at this tool, what it does is it separates risk categories into 4 different categories: primary prevention, secondary prevention, tertiary prevention, and then catastrophic or highly complex patients. And those are based on the complexity of care, but also the amount of resources that are utilized by the patients. Healthcare resources and dollars, healthcare dollars as well. And then there are different levels to each of those categories. So primary prevention has 2 levels, level 1 and level 2, secondary, level 3, level 4, tertiary is level 5, and catastrophic is level 6. So that's obviously the most highly complex patient. And there are some examples up at the top in table 1 that provides some examples. They're examples. They provide examples of clinical diagnoses and behavioral health diagnoses, any special needs, potential physical limitations, social determinants of health, utilizations and claims data, and clinician input. So these are the type of resources that you may be using to make a decision as to what risk category you would assign a patient to. Primary prevention is exactly what it says, that the goal is to prevent onset of disease. The patient is healthy, they have no known diagnosis. Level 1s have no known diagnoses and is healthy and has no significant risk factors. Level 2 they're healthy, but they have significant risk factors. They may have a family history of diabetes. They may be overweight. They may smoke, but they don't have any diagnosis of disease. They would be patients that would typically be assigned to this category. Secondary prevention, the goal is to treat the disease and avoid serious complications. So the level 3, the patient has disease, but it's controlled. So they might have diabetes, but their hemoglobin A1C is 6. They may have high blood pressure, but their blood pressure is controlled on medication. So we want to keep their disease in control and prevent complications of disease. A level 4, which is the first level that actually by policy or procedure or protocol would get referred to care coordination, is a patient who has a disease or a complex treatment and is at higher risk for complications or potentially significant risk factors. So that's your patient that actually has hypertension that's not in control, diabetes that's not in control, that needs to have some support, has to have an advocate that is assisting them with linking them either to resources for getting their medications, for seeing their specialists, transportation, chronic disease self-management classes. Those are the type of patients that we usually see in level 4. Level 5 is the patient, we treat the patient who has late or is in final stages of disease, excuse me, and we want to minimize their disability. So this is the patient who has hypertension and diabetes and smokes, who's had a stroke. So they've had a significant end organ dysfunction due to their uncontrolled chronic disease. And now they have some disability, and we want to prevent increased disability. Patients who have had a heart attack and may have some class 2 or class 3 congestive heart failure, and we want to keep them get them to the lower side. They are more require more intensive resources and need more help. And then the catastrophic and complex patient is it mostly ranges from restoring health to only providing comfort care. So these are your hospice patients, your patients that have multiple organ dysfunction and end-stage kidney disease. They're on dialysis. They're disabled from work. Patients that cost a lot of money, basically, in healthcare, but require a ton of care coordination between primary care and specialty services. So what we're missing out of here is really kind of the behavioral health piece of it, but they are included under the clinical diagnosis and behavioral health part. And the care plan also includes those behavioral health diagnoses. So we, in primary care, that we make it very clear that that is a key consideration in doing risk stratification and figuring out where your patients need help. Identifying the burden, disease burden, and determining the health risk status. Part of this program and what you get from the American Academy of Family Practice is each of the questions. Is the patient healthy with no chronic disease or significant risk factors? That's your assessment tool. If the answer is yes, then they're a level 1. If it's no, you go to the next question. Is the patient healthy but at risk for chronic disease or has other significant risk factors? I'm pointing to the screen. You probably can't see me pointing to it. But I'm looking up here in these little arrows up here. And if the answer is yes, then they're a level 2. If it's no, you go to the next one, and so on and so forth. And then once you make that determination, again, here it goes over the goal again to prevent the onset of disease, but it also gives you suggestions for the care plan. And so this is something that you can create templates in your EHR for the physician's plan of care. Whoops, what did I just do? Sorry, I was playing. Let me previous this. There we go. I found another way of advancing it. You could actually put those care plan suggestions into a template that the provider could check once they've determined what level the patient is, so that we can say that we're talking to the patient for the plan of care. And we'll get a little bit more into that on the next slide. So the sample procedures, and I do have some sample policies and procedures for implementation of this specific risk stratification model. So if you want that, let me know or let Joe know. We do have those samples as well available. So on the procedure, the assessment assists the physician and the care team in predicting the healthcare needs. We just talked about that. Based on the outcome of the risk assessment, a care plan can then be developed in collaboration with the patient or family. It doesn't have to be a nursing care plan. So a lot of people feel that when we say a plan of care or a care plan needs to be developed, that it's the kind of old-fashioned nursing care plan where we give nursing diagnoses and do our assessments and interventions and planning and all of that type of stuff. That is not what we're talking about. The plan of care is the piece where the provider has made the determination of where they're at risk for complications or complexity of care, and then they have set that plan of care. And by, again, using those care plan suggestions that we have, but it's in their plan template, usually on their EMR. So there doesn't need to be a special plan of care, particularly for levels 1, 2, and 3. 4, 5, and 6 generally do. Once you get referred to care coordination, then the plan of care does become more complex. And there are templates that are available to help initiate what it is that you're working with the patient on for chronic disease self-management, linking to community resources, that type of stuff. And we take the care plan and category of health risk to identify the patients using the following information: the CCSA, what their clinical diagnoses are, utilization of data from the insurance or other sources, and then the clinician's personal knowledge related to the patient's total social, financial, mental, or physical condition. I'm not sure if I put this in here or not. So we just talked about this, and we did talk about that too. It's in bigger print, so I'll leave it there just for a second for you to look at. Patients who are healthy, have no level 1 and 2, are assigned to a low risk category. 3 or 4, the disease is present. We want to prevent end organ damage. 5 and 6, disease has complications and or complex care. These patients here, specifically in the tertiary prevention category, usually rank high in healthcare resource expenditures. Patients that have issues with frequent emergency department utilization and frequent hospital admissions could be assigned to this category, especially if there's a significant decline in health status. In addition, patients with extreme or catastrophic situations, such as highly complex treatment and require intensive care management, are a level 6 as well. It just kind of helps to categorize your patients and to establish your resources that you have in your practice. And again, here are the questions on how you determine what level they're at. So I'm just going to kind of go through these because we talked about it already. So the patient's primary care provider selects the risk level at annual visits or with any change in patient status that requires an increase in care management resources. Care coordinators may also assign risk levels, especially when you're doing the core comprehensive standardized assessment on your Medicaid patients. Sometimes the care coordinators are doing that over the phone prior to their annual visit. And they've identified some significant risk factors, and they'll usually flag that patient for the provider or talk to the provider before the patient comes in with regards to whether the patient needs to have a care coordination referral or not. In general, patients with a risk level of 1 through 3 can be managed by the primary care team. They don't need to go to a special care coordinator. Referrals to care coordination can be made though, just because they're a level 1 to 3 doesn't mean you can't refer to care coordination. If there's a specific situation that you need help with and would like a care coordinator to intervene, that an individual referral can be made based on a provider request. Patients with a risk level of 4 through 6 should always be referred to care coordination for an assessment for complex care management. So the assessment generally gets done, and then the plan of care for what interventions are required, basically to keep the patient out of the emergency department, keep them out of the hospital, keep them home, and keep them in the best condition as possible. Other models of risk stratification. So this model, the AAFP model, again, I think is very comprehensive, very appropriate for primary care, more difficult to implement in a behavioral health setting. But the other part, or the other piece of risk stratification actually is already happening. It's happening with their insurer. So the patient's health insurance plan are looking at their claims and utilization data that health plans identify their own patients that are high risk or low risk that need case management. You could and still meet the requirements here if you are actually using gap reports from your payer. You could actually say where our care coordination department in our practice are using payer gap reports. We're going to look at any patient that requires transitional care management, so patients that are transitioning from the from hospital to home, from the mental health aid, hospitalization to home. There's different pieces of that for transitional care management. You can say that our care coordination department is going to do transitional care management. We're going to deal with patients that are high utilizers of the emergency department, any hospital readmission, and then we're going to also look at payer gap reports. And that's kind of how we're going to run our care management department. What doesn't happen with that piece of it is the behavioral health integration part of it. So the AAFP model, risk stratification model, really incorporates that behavioral health piece into it. So from an IDN perspective, from a PTN, from the Practice Transformation Network, you just using claims and utilization data and payer data would be perfectly appropriate. But from the IDN perspective, there really isn't a ton of the behavioral health integration that happens with the risk stratification. It's going to happen once the patient's risk stratified into care coordination. Then the care coordinator is going to follow the model that is recommended for the multidisciplinary core teams in getting the patient. So, and that will incorporate the behavioral health integration piece of it. There are EMRs that have predictive risk modeling software that's built into it that can stratify patients by their diagnosis, by their payer, by age, by gender, by utilization, by their social determinants of health, looking at health risk assessment scores, looking at the number of medications that they're taking. They can stratify by low health literacy, non-compliance issues, lower patient engagement and education, lack of community infrastructure, or caregiver involvement. That is a much bigger piece of looking at the population. So when you're using risk modeling software, you're actually looking at a bigger population, and you can make a determination as an organization on what you're going to focus on for stratifying risk and care coordination piece of it. But again, when you're implementing care coordination within your practice, you need to identify the population that you're going to be serving. And for the IDN, again, for the IDN aspect of it, we want those highly complex patients that have behavioral health diagnoses and chronic disease medical diagnoses as well. So identifying what attributes to the higher risk patient, again, I talked about that. If they've been on oxygen within the past 90 days, they've been hospitalized within the past 90 days, you set the time frame, you set the condition, and then you can risk stratify that way. The key to risk stratification is to just do it and not stress out over the complexity of how do I stratify risk. Pick something and just start doing it. Consistently, the AAFP model, again, when you first look at it, because of the 4 categories and the 6 levels and the care plan suggestions, that it looks so complicated and complex. It really is not. It looks that way because it's so comprehensive. And it's a great tool to use, and it's very easy to implement. And if we can get it past the providers, which is usually the key barrier in doing it, they like the American Academy of Family Practice. It all makes sense, but they just, how are we going to do that? How can we take 1 more minute of our time to do 1 more thing when I'm trying to see the patient and get this stuff done? But it really is a part of promoting the teamwork, and it really, once they start doing it, it takes less than 30 seconds to assign the risk, because the provider really knows the patient so well that, and then they get to know the model so well that they can clearly just put the patient into a 1, 2, 3, 4, 5, 6, circle it, and hand it off to their medical assistant and move on with it. So basically, your complex patients need care coordination, and how are you determining who needs it in your practice? I'm done. Now we have time for questions.
Thank you, Jill. We didn't have any questions come through in chat, but if folks have any, you could feel free to do that now. I think you might all be on mute at the moment, so we could open that up as well, and possibly take them verbally. But a couple of things I just wanted to share watching Jill's presentation. You know, one thing I want to touch on is the predictive modeling piece. That's something I have a little bit of experience in. And not only do EHRs have features built in to do that today, but there are also products out there that can just do that standalone and not only look at some of the things that are hardwired in EHRs, but look at your data that you might be collecting and identify whatever is contributing to someone's likelihood of succeeding in treatment or not, and then risk stratify people based on that data. So I think that's a really interesting kind of brave new world for healthcare, is to be proactive about that, because it almost becomes like any sort of assessment you'd give a patient at that point, to be able to say, gee, because of these correlated variables based on the statistical analysis, this patient will probably not do as well as another one. We can make decisions today about their care, and I think that's really exciting. The other piece I loved about Jill's presentation was just do it. I used to work with a customer of mine in Oklahoma that was an early pioneer in integrated care from a behavioral health center perspective. So they basically took some therapy offices and turned them into exam rooms and hired nurse practitioners and go right to your case manager and left to get medical care. And they kind of said, spoke really eloquently about going through a process to say, we can't do this. How are we going to do this? We don't have time to do it. We don't have people to do it. We don't have money to do it. And my colleague there gave a great presentation about what he called the power of and. You know, if you think about things in an or-driven paradigm, you can do this or you can do that. You'll always only do one or the other. But if you start to tune into the idea that you can do something and something else, you can make tremendous headway in different types of initiatives. And so that was really neat to see in the presentation, because I think risk stratification is something that's newer for people, and is the kind of thing a lot of folks might just say, gee, that's nice, but we don't have the time. We can't make that step. But I do think better understanding who deserves your highest level of resource and who might need extra attention to have a better outcome is a super valuable thing in healthcare today with limited resource and staff.
And the ultimate goal is to make sure that the patient has the best outcome possible. And in doing that and providing the coordination of care for your patients and more teamwork, it really is taking the end component of having that sicker patient off of the hands of the provider, right? So we're kind of spreading the pain through the team with regards to the amount of work that has to be done. But the ultimate outcome of better patient care, higher quality outcomes, really is kind of the ultimate goal. And ultimately, even though it may seem like it's going to take a lot of time up front, in the end, the provider should be having more time because the team is taking care of the patient, not just the provider. And so that this is just kind of a way to incorporate that care coordination into your workflow.
Excellent. That's really great. And you know, the other part of this, if you kind of look forward, is how does this approach help you compete in a values-based environment where you're compensated for outcomes, not just for the fact you provided the service. And so being wiser about how you assess and triage through a risk-stratified model, again, becomes real important for vitality of organizations in addition to the outcomes of the patients.
Right. Any comments or questions from anybody?
Wonderful. Well, with that said, we'll kind of wind down here. We appreciate you all joining our presentation. We will send along instructions and a link to the pieces, parts that you need to complete for continuing education credits. So stay tuned for that for our IDN 7 partners. And we appreciate you being here today. And if you have any thoughts or feedback about upcoming topics, let us know. Stay tuned for a December webinar coming up soon. Thank you very much, everybody, and have a great day.